Welcome to Dr. Tom Meets. I'm Dr. Tom, former vascular surgery resident and now the founder and CEO of Heidi, one of the world's leading AI companies in healthcare. And I'm joined by Christina Farr.
Hi, everybody. I'm Christina Farr. I am a health and technology writer with Second Opinion Media and an investor from New York City.
In Dr. Tom Meets, we're going to be talking to health system CEOs and tech leaders about how we should build the future at the intersection of health and tech. We're going to be meeting Stephen Klasko. So Stephen is an obstetrics and gynecology physician, but he's had an amazing career. He's one of the few OB-GYNs that's ended up as a health system CEO. He's now working in VC. I've never met him before, but I know, Christina, you've seen him before a few times.
We go way back.
Yeah.
We have spent so much time together over the years. He's honestly made me tear up listening to him speak about especially obstetrics, which is an area that he continues to be deeply involved in. And now to see him branch out into entrepreneurship and the way that he always has time for founders, which I think is one of his most special qualities. And then he and I have also both written books. So we've definitely commiserated on that.
Thought deeply about, issues, the health system, all these things. Yeah. So let's head to Stephen now.
Steve, you are so unique in so many ways. Not to mention you have the coolest glasses. I've told you that before. I just love them. But also the fact that you started out as a health system executive, and even before that, an OB-GYN. So this is like a unique path that you were an OB-GYN turned health system CEO. You might be the only one of all time. And then from there, took the leap into startups and venture capital. Again, it's just not a path that many in the field have taken. So I want to start at the beginning and just ground everyone listening in what it was like for you as an OB-GYN, and then just kind of take it step by step and how you managed to cross the chasm so many different times. So take us back to the early years, Steve.
Yeah. Well, so you missed one link. I actually started my career as a disc jockey. I was a broadcast journalism major and a chemistry minor.
I love it. Okay.
I got fired from that job because I broke a rule. So that's been a common theme. My minor was chemistry. I went back to my Lehigh University. I said, what am I going to do? They said, well, in a weird way, you've taken enough chemistry courses that you could apply to medical school. I said, well, why the hell would I want to do that? Well, again, you're not going to be a DJ. You just got fired from your first job. And so I took the MedCats. I got a special delivery rejection for my first medical school interview because I decided to debate the arrogant neurosurgeon, a little bit of an oxymoron. But the second medical school, where I ended up 20 years later becoming dean, which is Drexel University College of Medicine. My DJ name was in Philadelphia. I was Midnight to 5, Little Stevie Kent. Kent is my middle name. And in my one pager, when I was getting interviewed by Drexel University College of Medicine, they weren't that impressed with my MedCats or my science GPA, but in the bottom it said Little Stevie Kent, WISP. And they go, oh my God, you're Little Stevie? Turns out my interviewer was an OB-GYN. They come in a lot from Midnight to 5. And he said, I've almost missed some deliveries listening to your stories. It turned out that the head of admissions was also an obstetrician. Calls him up. He says, Dr. Spector, we have little Stevie Kent from WISP applying to our medical school. And I got in 2 weeks later. So then I basically became a private practice OB-GYN. There are not many private practice OB-GYNs that went to a 3 resident a year residency program that ended up becoming dean of 2 medical schools and president and CEO of a place like Jefferson. But I went to Allentown, Pennsylvania, and built a practice from 8 deliveries a month to 50 births a month. Literally doing what we now hire consultants to call patient-centered care, but we actually provided patient-centered care. We didn't need McKinsey, we didn't need Accenture. We just said if somebody called me at 5:30 and was uncomfortable, I'd see you at 6. Or every single patient I saw for a yearly exam, I asked them 3 questions, just about their life. And my son Josh is on the tennis team at Swarthmore. My husband just had prostate cancer. So when I saw them for the next year, instead of just saying, okay, we're going to do your PAP, I asked them how Josh was doing, how their husband was doing. So people felt really that they were able to talk to me at a different level. And we built up this really large private practice. And I'd still be delivering babies in Allentown, Christy, if it wasn't for the fact that back then, 98% of OB-GYNs were male. The number one performed procedure was hysterectomy, followed closely by C-section. And I'd never done anything academically, but I happened to listen to as I remember him, an old OB-GYN at Penn State. Actually, he was probably my age now that I think about it. It's a little depressing. But talking about hysterectomy, he said, if you see a small fibroid, just take out the uterus because a woman doesn't need that. I ended up taking an 80% pay cut and doing the early work on psychologic and sexual effects of hysterectomy, and went into academic medicine, became a chair of OB. And then when Allegheny went bankrupt, they asked me to become dean of the medical school that I went to, Drexel University College of Medicine, who had taken over from the Allegheny bankruptcy. From there, I went to University of South Florida, which interestingly is not in South Florida, which tells you everything about academics in Florida. It's in Northwest Florida, and did three interesting things there. We started the largest simulation center in the country because I'm a pilot, and every 2 years I have to get my technical competence assessed, but nobody ever checked my surgical competence. We started the Villages Health. It was 200,000 seniors that were dictating their own care through primary centered care. And then we also started the first medical school in the country, partnered with Lehigh Valley Health Network, 1,100 miles away, that chose students based on self-awareness, empathy, communication skills, and cultural competence. And then I got chosen to be the first ever, president and CEO of Thomas Jefferson University and Jefferson Health. And we went from $1 billion to $10 billion. That's my story.
Steve, I feel like before we get into what you're doing now, I'd love to take a little bit more of that step back into the time that you were an OB, because I think right now what's going on in OB is just heartbreaking in the States. And, Heidi's a global team, so is seeing it from all different perspectives. But how do you feel now, kind of looking around at what you're seeing? And I'm sure that, while you were no longer delivering babies, I'm sure that part of you, you're always going to have that identity in some way, shape or form. So we'd love your reflections on that.
Yeah, and I delivered babies in most of my jobs. The only one that I didn't was Jefferson because of the malpractice environment there. But what's happening in obstetrics, what's happening to women in the United States is really horrible. We spend, a few times more than any other country per obstetric patient. But our outcomes have not gotten better in the last 10 years. And there's so many reasons for that. I mean, you have C-section rates of 35 or 40%. And I'll give you one example. I was on the board of a company called Nuvo, based out of Israel, which was doing remote obstetric monitoring, right? So if you need 3 non-stress tests a week for preeclampsia, if you have money, you can pay to park and you can go and, get a nanny to watch the kids. But if you don't, you just don't get those non-stress tests. We couldn't bring it to America for 2 reasons. One is it's hard to get somebody to do something when their salary depends upon them not doing it. So you get paid in hospitals to have people come to the hospital and do the non-stress test there. And the second thing is the malpractice environment really kicked in because literally when we started our first pilots, we literally had these commercials from malpractice attorneys that, did your baby get delivered and monitored using that new Nuvo at home? Is your baby not perfect? Call Schwartz and O'Reilly, and we'll do a consult. So we have some barriers to care that create this huge health equity piece for people that can't get access to a broken, fragmented, expensive, and inequitable system. Obstetrics is where it all comes together because we've never done a great job of really thinking about women as well as we should. As one of my patients brought up to me when I was doing her pap smear, she said, it's curious to me that at the moment you guys discovered prostate and had to get an invasive digital exam, all of a sudden you came up with a blood test of a PSA where, with women, we don't really do that. I think it's really sort of sad that we have taken all the resources we use in healthcare and have not done it to make sure that's probably our most important resource, which is women and the next generation of folks are getting the care they need.
And just not dying in childbirth, which, in other countries like Australia, doesn't tend to happen. But in the States, despite all this money we spend, we're losing women all the time.
I gave a talk about this in the Gold Coast of Australia, actually. I think we don't spend enough time talking about what those roadblocks are in the United States that don't allow us to be best at. We have to get over this myth that the United States is the best healthcare system in the world. It's a little bit like, no, Denmark does not want to be in the United States, and we have to stop thinking that the United States has the best health. The United States has the best healthcare system in the world for 15% of the population, or 20% of the population.
Yeah, like Christina and I were just talking about how this idea of privatizing things is great when people have choice. But when you're pregnant and you need antenatal care, do you really have choice? Like the majority of patients probably don't. Like they hope they get some care. Do they really want to select from? It's not like buying a phone. Like they just want to be seen by someone. And especially if they're sick, they're just going to whoever's nearest to them.
And by the way, guess how many visits pregnant, once you deliver the baby and they send you home, guess how many visits the American system pays for after that?
Yeah, I couldn't believe it. It's insane. Like,
it's one, by the way.
I mean, we can go even beyond the healthcare system. Our maternity benefits generally are not as great. My daughter got her PhD in public health, had 2 babies, and got it like 6 months early. And I won't mention the university, but they did an editorial of, Lynn's the kind of student we want. She had 2 babies, and she still went back and got her PhD. And she wrote a letter to the editor. Yeah, that's because she had really lousy maternity benefits, and I had to go back. I mean, here's the issue: we don't have a social medical system in the United States. We have a sick care system. And when I first met Hemant, we wrote that book on healthcare, A Manifesto for Health Assurance, of how we go from a sick care to a health assurance model, which we still haven't done.
And Hemant, by the way, is Hemant Taneja, runs General Catalyst, just for people listening.
Yeah, exactly. Yeah.
We met, and that's not who I work for, but, it started with, as he said, a very long latte or a few lattes in Palo Alto. And we said, what if a Silicon Valley entrepreneur and a CEO of an academic medical center had a baby? What would that baby look like? And that's what we tried to create at Jefferson.
I'd love to get into the general capitalist view of the world as well, because as someone who's sold to health systems, it's really, really tricky, let alone being an Australian, which is, weird enough, to understand what the right incentives are. But maybe just one more question about obstetrics, and maybe antenatal care is when I wonder about, like, is there a way that maybe the AI or other tools like antenatal care gets better, that in a way that can actually fit into the US health system's incentives? Like, you're an optimist, or do you think there just needs to be like a fundamental change?
I'm optimistic about what could happen. I mean, I really do think with sensor technology, and once we get to the point where we can really start to look at how it's not just the AI, it's just what we do with those signals and how to separate the noise in the signals. I can see a future where, and this is a little bit what Nuvo tried to do, but that where somebody would literally have a belt that's high risk and literally send continuous signals, a little bit like what is starting to happen with arrhythmias, where you can literally send out an emergency signal if you're having a PVC. I can see that happening. The problem becomes, how do we not use this technology to make the wealthy healthier? And that's something I really worry about. And it's not just the money, it's also the education and starting to create these models in a way that people of different cultures can understand. And we've just done a lousy job of that. So I'm incredibly optimistic of what the technology could do in obstetrics and give us really early warning signs for things like premature labor or preeclampsia. The other thing to recognize that, and I think we get so caught up in how good we are, that there's certain things in obstetrics that we're still in the bloodletting stage of. Nobody knows what causes preeclampsia. Today, in 2026, in fact, at the University of Chicago, I think they have like a cornerstone, set for the person that discovers what causes preeclampsia. And I'm going to say it again. We don't put enough money generally into research for obstetrics. You can check off, I'm optimistic of what AI and technology and sensors and maybe even nanotechnology could do for not ever having a stillbirth or the kind of things like premature labor, preeclampsia. I'm less optimistic that we'll come up with an economic system that allows those things to flourish.
Before, where you mentioned the getting a nanny, for instance, or the time off work, that you could have the most sophisticated sensors in the world sending, a woman who's pregnant signals. But what do you do when you are at a job that does not want to let you leave? And what do you do when you have existing kids at home? Yeah. And in some cases, what about the lack of transportation to even get to that hospital, which is where I think it's really incumbent upon us to talk about the social side of things. And it feels like we are in a moment now, at least in the States, where we're not having those conversations because it's a moment where you can't talk about inclusion. It's a moment where you can't talk about equity in the same way. It's this kind of strange political piece where it's like okay to talk about technology and innovation, and we do all the time, but then how do you connect the dots of wow, amazing technology and AI through to patient impact?
Yeah, the thing I never envy with the US system is like, how do you find the incentive? Like, is it, you're just always going to have to build like some sort of like tech enabled service just for women's health that then like limits you to a band that can pay for it? Maybe you can get employers to pay perhaps in like very competitive industries, but it's just like really tricky thing to solve. Yeah.
I've been doing this for 40 years. I use this quote in my talks from Jason Kidd, who is a point guard for the NBA, and he went to the Dallas Mavericks and they were 24-52. And he got up in the press conference. He said, I'm going to turn this team around 360 degrees. I can tell you in 40 years, we've turned things around 360 degrees a lot in some of these, social determinants of health issues, and we think if we just say the word of SDOH, then okay, we're absolved. I don't want to be utterly negative because some of the things we do are really good for individual patients. The problem is we sort of have a Star Wars technology for individual patients when I take care of a high-risk obstetric patient in a Fred Flintstone healthcare delivery system. We are stuck in a way that really the system in the United States is not set up for people or the patients. When I was the CEO of Jefferson, I spent a lot of time thinking about what about the 97% of people that don't wake up in the morning thinking they're a Jefferson patient. They're a person that might be pregnant, that might have diabetes, that might have congestive heart failure or COPD. Health systems tend not to think about that. What's our patient? What happens when they come into my hospital or my outpatient center? I'm the board chair of a NASDAQ company called DocGo, which started as a transportation company with 12,000 ambulances in the UK and the US. But what they're literally working to create is this healthcare at any address piece, where literally we provide as much care at home as we can. So theoretically, I'll give you an example. When I was the CEO of Jefferson, we did a joint venture with DocGo, and we would have Medicaid patients that would come in 6 times for asthma into our ER. As a CEO of a health system, you're thinking, God, I'm losing $10,000 every time they come in. How can I just lose $5,000? Okay. Fast forward, I acquired a Medicaid insurance company, and we partnered with DocGo. And they would come in and do a home health exam and say, 97% of those patients have mold in their house. So it made more sense for us to hire handymen and handywomen to take care of the mold so they didn't come into my emergency room. But how many health system CEOs would think of that if they don't own an insurance company and if they haven't partnered with a company like DocGo? And other countries have done a much better job of starting with the person, not the patient. And how do we look to the health of that person?
And bringing it back to maternity care, it's the same thing, in other countries where they don't just discharge you and say, bye-bye, good luck with the baby. There are home visits baked into the model, both before you have the baby and after you have the baby. And the overwhelmed mother who's, really struggling has somebody to talk to and guide them. And in the US, they just kind of say, good luck. And I think to your point, Steve, it's the lack of that, bringing care outside of the health system. It's that problem of the sick care system that leads to all this unnecessary cost because we don't set foot into the environments where the patients live.
You look at things like postpartum depression, you look at frustration around lactation, you look at, literally even, folks that are underserved and their nutrition while they're breastfeeding. And all that, really often all that needs is somebody that's able to come into your house and, give you a pat on the shoulder or say, no, try this, especially with lactation, it's often just a minor adjustment. But you're 100% right. our system is, okay, we did the delivery, you popped it out, we'll see you in 6 weeks. If you have a problem, call the nurse in my office. That's just not the way to go. And, that's what's so frustrating about what's going on now in our country politically, because the concept of, and I hesitate to say it, but the concept of make America healthy again, starting not with drugs and surgery, is a great concept. The way it's being implemented is clearly, by and large, other than maybe getting the phosphates out of Fruit Loops, is not really being implemented.
Yeah. In America, one of the big changes that's underway now is that millions of people will lose access to Medicaid, which is the health insurance that is really there for people who are underserved. And it's studies are being done showing that it could be more than 12 million people, which, Steve, that is going to have an impact on health systems that I would love your perspective on, because there is a Hippocratic oath. You'll have all these patients coming into the health system that no longer have any kind of insurance. And my guess is that they will still need to get treated. So what does that mean for the longevity, the financial health of a health system, with so many people uninsured?
As the Australian, just practically, what do you even do? Someone's at your door, you're a doctor, you're trained to take care of people, to, come to someone when they're in their moment of need. And it's do you ask for the credit card first? How do you do it? I don't,
Health systems generally in the United States do a really good job of taking care of everybody. When I got to Jefferson, we were one hospital, one campus university. I left 9 years later. We're 18 hospitals. We merged our health science university with a design university. We had a Medicaid insurance company. But the most important thing I did was we changed our mission. Our mission had been, when I got there, we want to be the premier academic medical center in Philadelphia. Well, nobody cares about that other than you and your mother, number one. And Philadelphia was like the second poorest city in the country. So we changed ours to We Improve Lives. And our vision was reimagining healthcare education discovery to create unparalleled value. And what that did is it changed how I incentivize everybody. I had 50% of my personal incentive was reducing 5 healthcare inequities in Philadelphia that had nothing to do with Jefferson. And we had to partner with other people. We had to partner with social organizations. So, and I think generally health systems will take whoever comes in, but the economic model is such that other than a few for-profit health systems, health systems are struggling to get a 1 or 2% margin. And the Medicaid situation is going to make that much worse. In New York today, there are 15,000 nurses on strike. The dilemma is what they're asking for is staffing levels and other things would cost another $3.5 billion, for Mount Sinai and Montefiore and Presbyterian. And these folks are running at barely a 1% margin. So the question for our country becomes, while you have the payers and pharma are doing fine, PBMs are doing fine, some health systems are doing fine, the majority of nonprofit health systems in urban areas that are taking care of everybody, can't survive with political ineptitude, which is what's going on now, and the payment structure as it is. By the way, the Republican side is, all right, let's cut costs by just denying the care to a bunch of people. The other side is saying, well, we don't want to do the hard work to transform, so let's just put a lot more money into the fact that we're already 18% of our GDP and extend the COVID subsidies, so we don't have to think about upsetting anybody that's lobbying for us, like payers or pharma, right? I would give you 2 sort of examples of 20 years from now, how we will look at this system as absurd. One is we're one of only 2 countries that allows direct-to-consumer pharma advertising. You can't watch a morning cable show anymore without, do you have stage 4 lung cancer? Ask your doctor about this $200,000 drug. Now think about this. If you have stage 4 lung cancer and your doctor doesn't know what drugs are available, the PSA should be get another doctor.
And there's AI now. So it's
Right. And why would they spend all this money to advertise for things like, stage 4 lung cancer? Because that drug is much more expensive than any of the other drugs. And it's like pit bosses in the casinos. They're hoping that they can convince doctors to give the more expensive drug, and that's the ROI. So that's just one example. The second example is what happened during COVID. We had a system that was absurd and evil, right? Jefferson lost $800 million during that period of time because people weren't coming into the hospital. We were taking care of everybody. This is pre-vaccine, and getting underpaid. And the insurers literally had record quarters.
United Healthcare had the most amazing run. It was
Yeah.
astonishing.
I listened to one of those quarterly calls, and this is what the CFO said. We had our best quarter. We had whatever it was, a $3 billion profit quarter because people that we had assumed would come into the hospital didn't come. No, they died, dude.
Yeah, exactly.
It's not that they decide not to come to the hospital, because here's the issue. In Philadelphia, the home of Comcast, fourth or fifth largest city in the country, there were 5 zip codes without broadband. So here's what happened. Somebody would have chest pain, and their wife would be on, their partner would be on CNN and say, God, getting a little chest pain. I should go to the ER. Well, the CNN said, unless you really have to, you shouldn't go. Why don't you go to sleep, honey, and we'll see how it is in the morning. That person died because they couldn't get onto Penn Connect or Jeff Connect. And that was a boon to insurance companies. Now, they didn't do anything illegal. They didn't do anything wrong. They did a lot of 30-second commercials with all that money about how awesome they were during COVID. So I think, it's a system issue. It's a system problem.
I'm just going to throw out one more really depressing study that happened during COVID that also ties back to obstetrics. We had really good maternal health outcomes during COVID, especially related to premature births. And one of the prevailing theories was that women got to rest during and actually take naps.
Less stress. Yeah.
During COVID because of work from home.
Yeah.
So, and in America, there is, not any mandated leave. Yeah. So, let that settle in for a second, and just the system that we have. But Steve, what I want to ask you, and I think is a source of huge misunderstanding in the States and, maybe even globally, is, so my husband just had an experience where he got something stuck in his esophagus and couldn't cough it out. It was like going on for hours. We have a physician friend we called, and she's like, look, you got to go into the ER for that. Like that's worth getting seen. So he's sitting in the waiting room. Somebody comes in, does a blood pressure check, leaves again. He hasn't seen a doctor at this point. I think it was like an intern or a nurse. And then it resolves. He just coughs it out. It resolves on its own. And he just stood up and he left. He wasn't at no point did he really even see anyone. He just stood up and left. And 2 weeks after that, we got a bill. Guess how much that bill was?
$500.
$1,800 for the privilege of going to an emergency room, sitting there, and then leaving without receiving any treatment whatsoever. So those stories make their way throughout the press. We've all read stories like these. If you live in America, this has happened to you many times. And yet hospitals are operating at 1 or 2%, you just said, profit margins, and many of them struggling right now financially. So how can costs be so high in America compared to the rest of the world? And yet hospitals and providers still continue to struggle.
It probably requires more than a few minutes to
this is a big one.
and maybe some alcohol. I think it's really a combination of factors. One is there is this thing in the United States around patient expectation. I'm not talking about your situation, but in most countries there's algorithms about what happens. So your kid hits their head and they don't lose consciousness, and you go to the ER and say, we're going to get a skull X-ray, we're going to do this test. I said, no, I want an MRI. Well, you don't really need an MRI. No, I want an MRI. Okay, so you do the MRI because the patients believe that they should get everything and somebody else should pay for it. That has a history to it that actually started with, people don't know this, but hospitals actually created the blues plans because they wanted people to use their resources. So, and then what would happen is in the 60s and 70s, literally employers, instead of giving patients more salary, would just give them all sorts of benefits. You can get anything done, when you go to a hospital. So I think that's one issue. The second issue is that the way we were set up, we were just allowed to be more and more inefficient. So before managed care and all the other stuff, if I became, as a hospital CEO, 5% more inefficient, I would go to the insurer and say, I need 7% more dollars. And the insurer would say, no problem. They would go to the employer and say, we're going to charge you 9% more. There was no disruptor. Everybody else has had a disruptor. Transportation had Uber disrupt taxis, Amazon, Netflix, everybody had a disruptor. We didn't have a disruptor because it was only, is another hospital doing it better than I did. Now, you could argue that the One Medicals of the world and that kind of thing were disruptive, but I would argue they were more us being clueless of how you can make money in primary care, right? So, but it's not like there's an Amazon of healthcare. And by the way, they haven't succeeded, right? Walgreens, when Haven started, I gave a talk for AHA. The week that got announced, Atul Gawande was going to be the CEO. He was still going to do neurosurgery and his New Yorker stuff. But on Thursday and Friday, he was going to transform healthcare. It was at Amazon, JP Morgan, and Berkshire. And the first question I got is, well, Dr. Klasko, why are you even going to work? Haven's going to take over healthcare. And I remember my quote was, I look at Haven like the Loch Ness Monster. If I ever saw it, I'd be scared, but I don't think I'm going to see it in my lifetime. Then we had the whole thing of Walgreens and Walmart. I remember at Health Evolution and Becker's, oh my God, Walgreens and Walmart are going to take over healthcare. Miraculously, that didn't happen. So the issue, I think, by and large, is if you're willing to take care of everybody that comes in the United States of America, with the understanding that we have incredibly unhealthy habits, we have a messed up social net and social system, as Chrissy made clear, and you're willing to do it no matter what the payment is, then the math doesn't work. And that it doesn't work for anybody. And that's the situation we're in. And the most efficient places can make the math work at a 2, 3, 4% margin, and the less efficient place can.
And then, of course, there's a lot of defaulting too. A lot of people just don't pay or go bankrupt. And so a lot of these costs have to factor in just millions upon millions, billions of dollars of non-payment, which is a whole other industry in the States.
So I've got a question that maybe flips it to, it's this dream world, a hypothetical, the best kind of place to be. So together, you're now supreme dictators. You can do whatever you like with the health system.
We already have one of them.
Exactly. Yeah. No, you
but
somehow.
Steve, you and I would do okay.
Exactly.
Make us dictators.
I'd fall into one.
I don't want Greenland. I don't want Canada. I'm fine with the United States.
Like, what would be the top 3 or 4 things that you guys would think of doing? Because from my perspective, again, I am an inch deep. I've never been a health system CEO, but the places I would go would be PBM, national PBM set by the government, negotiated with the pharma companies for the whole country. So there's no PBMs, like all banned, national PBM, set the price for everything.
Why not extend that and just let government set pricing like the rest of the world does?
Then for services, exactly that. So have for everyone, national insurance that sets a certain price, that you include the materials and the cost of operating for, like that we have Medicare, but Medicare is for everyone. And basically you have a set of services, a 15-minute GP visit, and then you also have a set of incentives. So if you take on a patient that has diabetes and you manage their HbA1c well, you get paid a bonus, right? And then, but you keep the other system and just see what happens. And I suspect that you will see resurgence of smaller practices because patients probably prefer to be seen in that setting than some massive rolled up system where I don't know my doctor, I can't get any continuity. And maybe that starts to tilt towards a slightly better system. But I'm very naive. I'm not the supreme dictators. You guys are.
I just don't know. I mean, I'd love Steve's perspective, but I don't know if the US, I mean, I guess I'm a dictator in this context.
Yeah.
But I could imagine the US a bit more being a catastrophic insurance system where everybody has insurance for if they get hit by a car and the rest of it cash pay. So you compete on price. I could see the US doing something like that. But then I would probably, if I'm a dictator, I would get rid of all this processed food, which is 70% of the American diet. And I might be a little bit spicy here, and I would get everybody eating a bit more plant-based, like more fruits and vegetables. Americans, only 7% even get enough fiber, which is a whole different thing. And now I'm talking about food, which is, very much part of the Make America Healthy Again agenda. But I don't think we're necessarily talking about those sorts of shifts. Like I'm all in on what Michael Pollan has to say, which is whole foods, mostly plants. So I would probably enforce that into the American diet. And then I would get rid of like this car culture, get people walking more. In Europe, Americans go to Europe and lose weight, and it's literally because they have to walk places and use public transportation. Yep. And all of that is so much more meaningful than I think we recognize. So those might be some of the things that I would do. But yes to everything you just said. I just don't know if it could be palatable for the average American. What do you think, Steve?
I would start with how we train healthcare providers. We still accept medical students based on science, GPA, MedCats, and organic chemistry grades. And we're somehow amazed doctors aren't more empathetic, communicative, and creative. It's beyond absurd that medical students still are chosen based on being able to memorize the Krebs cycle and organic chemistry. Like we assume everybody's going to be a physician scientist at Yale. So in order for all the things that Chrissy, my co-dictator, wants to do, as far as things like food and nutrition and exercise, you need to train a different level of doctor. I did a nutrition fellowship after my medical school, and I had to unlearn all the stuff that I learned in medical school as far as what you should do. So that's the first thing I do. The second thing I do is, and it gets back to incentives. People are pretty good at incentives if they can understand them. And I think this is where we could even use like AI. I have a 750 horsepower car and nobody would insure it. Okay. So I got this thing from Geico. Well, we'll insure it. We just want one little thing. We want you to download this app. So, oh, that's easy. So I downloaded the app. Turns out what that app does is monitor pretty much everything my car does. My phone connects and, it measures everything. And I said, well, I got to be smarter than Geico. So I left my phone at home, went out one morning and went very fast. And I immediately get this text. We noticed when I got back to the car, like the next day, we noticed you went 11 miles without the app. Remember when you signed your contract? So I can see a future where, we will give you, much better coverage and we'll cover everything, as long as you're willing to give up some of your privacy and let us see when you go to Dunkin' Donuts, are you just getting, Dunkin' Donuts is a coffee and donut chain in the United States. Are you just getting coffee or are you getting coffee and 2 donuts?
Okay, but now I gotta move this ahead one more time because we're the dictators and say we gotta abolish employer-sponsored healthcare. Because the reason that would not work today is because people switch jobs every 3 years and therefore leave their insurance company every 3 years. So literally no one cares about your long-term health and doing anything preventative, because if they care about prevention, then who's going to win? The competing insurer who happens to get you, which probably is going to be the government in 20 years. So we got to get rid of that first and foremost. Makes no sense that health insurance is tied to employment. And now we live in a time where so many people work for themselves, they're contractors.
What happens when you get sick? Unemployed.
Exactly.
Yeah.
The last thing I would do, and this would be controversial, but I would do a combination of 2 things. One is, we're not a country. We're sort of a combination of states, right? We have a federal government, but really things are run by states. So I would do a single payer by state. I wrote about this in one of my books called We Can Fix Healthcare, The Future Is Now. And the concept was, when Trump first got elected, of this book was, this was after Trump won. Obama got everybody together in healthcare and said, look, I created the Affordable Care Act, you guys fix it. We started blaming everybody that wasn't us. The hospital CEOs blamed pharma blamed George, and George blamed blah, blah, blah. So there was a science fiction, like sort of blackout and vapor, where all you could do is look in the mirror. I wrote with a guy from Wharton. We did 150 interviews of leaders that said, we won't use your name, but like, if you're a pharma CEO, what would you do differently? And one of the things that came out of that was literally the concept of, what if we created an incentive system by state? So in this book, we theorized that both the Republicans and Democrats came up with the same health plan. They called it different things, and there was some difference in payment models. And I remember Sanjay Gupta did a thing for it. He said the first chapter is called "When Politics and Healthcare Became Fun Again." So you know it's a science fiction book. The federal government would say you have to provide at least this care. And then each state would do an RFP for a single payer by state. What would happen after 5 or 10 years is we'd figure it out. But Vermont and California might say, to Chrissy's point, we want Medicare for all. Well, let's see how that works. Pennsylvania, where I was at the time, had 7 different insurers. Let them compete based on cost, access, quality, and user experience that they would have to renew. And then if you combine that with some kind of, to Chrissy's point, my co-dictator's point, some kind of sort of at birth health savings account, that if I'm employed, just like I'm putting in Social Security, I'm putting it into my child's health savings account that can get, over a period of time, grow. And if I'm not employed or if I'm underserved, the government would do that and put that into the kid's health savings account. The beautiful thing about that is you wouldn't have necessarily Medicaid. It wouldn't be the moment you call a hospital or a doctor or whatever, tell me what insurance you're on, because it wouldn't matter. It would just be who paid into your health savings account. That would get rid of the tale of two cities by a large amount. Now, we might, after 5 or 10 years, then decide, boy, of all these systems, this one seems to work the best, whether that's Medicare for all or whatever. And then what I would do today, if Chrissy and I ran United States healthcare, I would create a 9/11 commission for healthcare. Because I think we're exactly in the situation we were with 9/11, where we had to look and say, oh my God, we, not Democrats, not Republicans, we as a whole had failed to keep our country safe. And we ought to get some really smart people together and figure out how we can keep our country safe. If you think about it, we're exactly in that situation now.
This is like this commission. We got an Australian, we've got a Brit, we have an American. We got the seeds of this commission.
I can be like
right
the
now.
Squire or Jester. I don't know. Whatever you need. I'm serious. Look, you two know everybody. We could create. I'm really serious about this. If we had the opportunity, I had written, when I was working with the Florida Economic Forum, I wrote an article called, why we need a 9/11 commission for healthcare for the United States. But that's really what we need.
I couldn't agree more.
Yeah, like a state of emergency,
Tom,
like drop everything, just focus on what
How do you
matters.
feel about the decision to make us dictators?
I think you guys do well. I agree. I think so. Like, we get this perspective across the world. Like, I think Heidi's in 50 countries or something. And I do think the best systems are where there is some public and private force. You can't entirely public is bad, because then it's almost like welfare state set up. Everyone expects everything. There's like no market forces at all. But then on the other counter side, in the private case, if you're coughing up blood, you can't choose. So there's always going to be like a portion of healthcare that fundamentally
All right,
has.
give us the top 3 countries. You have to. I got to put you on the
I think
spot.
Australia and New Zealand are fairly similar. So I think Australia's got one of the best health systems. It's getting worse because we're privatizing it more. But there is this balance. So basically the way it works, for those that don't know, there's a national insurance. So everyone gets Medicare, no age gaps. It's just everyone gets it. There's a set of fees for any given visit, any type of procedure in primary care, and for specialists as well. The area where it's not so great is that most primary care docs and most specialists would charge some copay. So it's like, okay, I go see you, it's $100. The Medicaid gives me back maybe 50, and then there's a gap. So that's good, actually, because it creates a slight disincentive. It's not entirely free. So I can't just be like, I feel a bit unwell, I'm just going to take a day off work and rock up at the doctor. It's enough money that I have to be sick enough to actually want to go. Also, if I'm waiting, let's say for a knee replacement, there's 2 options. I can wait in the public, and I'll get triaged by someone like me, a surgical resident who's sitting there going through the list and saying who has the worst symptoms, who has the most pain. And probably, it's not perfect. Sometimes you have to wait a year if you're really well, but you'll get your surgery done. But if you can afford it, or you have private insurance, you can probably get it done within a week. Now this is like hard for some to swallow because there's obviously some inequity. You know, the person that pays gets it faster, but like there is just inequity in life. That's what capitalism creates. Different people have different resources, and so it kind of creates this like natural constructive tension where those that can pay, those that can't still can get access. But fundamentally, like if I get hit by a car, I can just go to hospital and I'm not going to have a bill and I can go back to work and be productive and I pay taxes. And I know in the health economics it washes out. Like I definitely pay for that service. So I think that kind of system is best. There are a few other places. The Nordics are amazing. They have like similar aspects. They do an even better job in prevention in a way that Australia doesn't. So they invest a lot in community programs. They have better kind of value-based incentives. Yeah, I'd say the Nordics and then Australia is probably like the best I've seen.
Yeah, I'm on the board of something called Future of Health, which is 60 global health system CEOs. I think in some respects, Germany has a really good. I mean, every country is different as far as the complexity, but I think Germany has a really good system. Australia, you mentioned. I think Singapore has a really interesting system with Sing Health. And I think Israel has a really good system, that works.
Lots of examples for the US to draw upon. But, funnily enough, guys, I was at this very strange conference a few years ago that was, you could only attend if you were a Fortune 100 CEO. And I was moderating the healthcare panel. And they told us that we could like quiz the audience. So I was like, I get to quiz all these Fortune 100 CEOs of, giant companies. And I asked them, what do you think is the best healthcare system in the world? And I had, Norway, I had Australia, I had the UK. There was probably 10 that you could choose from. The vast majority of these Fortune 100 CEOs picked America, which was like statistically not accurate at all. And it really prompted me to think that for this 0.1%, it is probably the best system of the world, which is the problem, in and of itself, that you get off the waiting list immediately. You get told yes to absolutely everything that you want. There is no navigation whatsoever. And I think that kind of excess is, what has created the situation that we have. So I think everything comes back to what Steve said, where the system just doesn't know how to say no and is not incentivized to do so.
You're CEO of a Fortune 100 company in Germany and you get pancreatic cancer, you can call, who's the best pancreatic cancer surgeon in the United States and get in tomorrow.
I was going to ask you, Steve, so this is very specific, a highly specific thing, but do you think selling to health systems for any technology company is generally a good strategy in go-to-market? So specifically for us, I think that it's exciting, and we take the health systems that
we're talking about the US.
Yes, US. So this is US. So where we have health systems that use the product and love us, that's great. But there's always this tension of like, well, like it's so complicated. I have to do this long sales motion. I have to compete with the medical records. Like, do I have a 10x product or is it just good enough? So yeah, it's always something I weigh up. So yeah, for startups like us, do you think would you have been a good customer at Jefferson?
When I got to Jefferson, I was competing with Penn, and it was like, hey, Steve, if you give us more money for NIH funding and get our protein, we can get closer to Penn in U.S. News and World Report and Blue Ridge rankings. I remember saying, if that's why you brought me here, it'd be like if height and hair were the two most important criteria, I wouldn't have taken this job.
Tom could have taken the job.
Exactly, yeah.
What if we become a 200-year-old academic medical center thinking like a startup company? And so the answer at Jefferson was yes, but here's what people don't understand. Literally, most health systems are literally run by the chief legal officer. The chief legal officer reports directly to the board. And in fact, I got asked by a legal group, how did you go from Jefferson being a place where good ideas go to die to being a top 20 innovation center? Did you have to get all new lawyers? And this is a true story, Tom. I didn't get new lawyers. I just asked a different question. I used to say, hey, can I do this thing, this new startup that Tom's doing? And the answer would almost always be no. Okay. Then I said, all right, well, I'm not going to accept that. So then when I start to ask, I would go, look, I'm crazy, right? I'm going to do this deal with Tom. Tell me how I can do it and stay out of jail. And then I get a 3-page thing about why I shouldn't do it.
Yeah.
And the last page would be, well, if you're going to do it, this is how you do it. So I would just skip to the last page, other than the 10% where they said, well, no, there's no way you can do that. So that's what got us to work with. I had a general catalyst person on my cabinet. literally on my cabinet. I'm going to give you one quick example of why that was such a game changer. So we're going through our budget, and my chief growth officer goes to me, Steve, if you can give me $4 million, I can do some digital marketing and some other things that I believe can get a 0.5% market share from University of Pennsylvania. I said, okay, exciting, that's great. 4 things later, Dan Goldsmith, who was the GC guy from Tendo, just was saying, hey, we just did a survey of 15% of the people that try to get an appointment at Jefferson never get one, because they're waiting too long on the phone or it takes too long to get the appointment, whatever the reason. So I'm not that smart. It took me about 3 more agenda items. Wait, Chuck, you want me to spend $5 million in marketing to get somebody from Penn or Temple to decide to go to Jefferson and get damn frustrated because they can't get an appointment and go back. So I said, why don't I spend the $5 million creating a digital front door, Dan, with GC, and then when that gets down to 2%, then we can talk about marketing. I believe that 25 to 50% of health system CEOs in the United States 5 years from now will never have been in medicine. They'll be good leaders and they'll be good entrepreneurs. I ran 35,000 employees. I mean, I'm a doctor, but I don't even know how to open Excel. All right, and I ran a $10 billion system. But I had somebody from Morton that used to say, you should always have 5 people under you that think they can do a better job than you and 3 that are right. And I hired people that were really good at that, but I was a great leader. The key is now, from your perspective, from the entrepreneur's perspective, you have to understand, as one CEO told me, Steve, you spent 40 years lying to us that technology would make our life easier, starting with the epidemic, right? Because you were selling, EHRs and all that. And it didn't do that. Second thing is, Steve, we were really tired of having to put all the Lego pieces together for all the point solutions that you guys create. I'm involved in 5 women's health AI companies. And their point is, yes, Steve, it's great that you have one around dense breasts and one around fertility and menopause and one around, bacterial vaginosis and all these, but why don't you put them together? And then you talk about founder egos and that kind of thing. But from their perspective, I don't want to have to put all those things together. Look, if you believe in your darn thing, then go at risk with us, right? Don't tell me how, it's going to affect, cost, access, user experience and quality. And then, you take no risks. And I think the one thing that I think is really important is, you have to recognize American health systems are really under siege financially. And this is a direct quote from one of the CEOs. Said, hey, I want to talk to you about this company. It's really going to help you around the future of healthcare. And when we get to value-based care, and this is what he said. He said, look, Steve, I'm having a financial heart attack. And you're like my dermatologist telling me you can move my liposuction up till next week. Bring in the interventional cardiologist. And the interventional cardiologist is, over the next 18 months, reducing total cost of care, measurable quality, measurable access, and measurable user experience that's going to affect my net operating income. If you can do that, then I want to talk to you. If it's about some great AI future that's going to, maybe happen, don't want to do that. We all have to look in the mirror. It can't just be, it's pharma's fault, it's the insurer's fault. We all have to look in the mirror. My new book that's going to come out is called Swifties, Startups, and the Singularity, where I come back from 2035. I'm the chief digital health officer for President Taylor Swift, because Swifties have become a political party and Taylor became the U.S. president. We could do worse.
Yeah.
But our healthcare motto is make healthcare tailored and make healthcare swift, neither of which was true in 2025.
I love that we're ending on this note of Taylor Swift. It's just perfect.
Yeah.
And maybe the inauguration song could be, "We are never, ever, ever, ever going back to that old American healthcare system."
Exactly. Incredible.
Yeah.
Well, thank you so much, Steve. Every time I talk to you, I walk away invigorated, not just because of the vision of the future that you describe, but just how real you are about the situation that we face today and the challenges that we confront. So
yeah, and great to meet you. Thanks so much for doing this.
Yeah, no, thanks. I really enjoyed being in your virtual living room, and thanks for everything you're doing.
Thank you for tuning in to Dr. Tom Meets.
Until next time, please like, subscribe, and you'll find everything about the podcast on HeidiHealth.com/podcast. In each of the show notes, you'll find the details to connect with the hosts, ourselves, Christina, and also everyone we had on the show. And until next time, thanks so much.